Chapter 13, Abdomen and GI. Starting off just with a diagram showing the different landmarks we're going to be looking at here. Beginning with the xiphoid process right there at the bottom of the rib cage, down through the costal margins, midline, umbilicus. McBurney's point there in the lower right abdomen quadrant is one we're going to want to pay especially close attention to when we talk about the appendix. Speaking of quadrants, here we just have a diagram showing everything from the right upper and left upper quadrants to the right lower and left lower quadrants. As with all of our conditions, we're going to start with the present health status. Do they have any chronic conditions or comorbidities that could be affecting the GI and urinary systems? Are they taking any medications? And how often do they have a bowel movement? Does it come at a regular schedule? Or is there any irregularities with the color and consistency? We would then move on to their past medical history. Do they have any history of issues with the abdomen or digestive system? Have any previous abdominal surgeries? Any surgeries to the urinary tract? Do they have any problems with any family history? Is there any leakage of urine? Any incontinence? Looking at their family history, any history of things like GERD, peptic ulcers, or stomach or colon cancers that could frequently run in families? Alcohol is going to be a major assessment here. Do they drink? And if so, how much? How often? Also, do they smoke? And again, how much? How often? And how long have they been smoking? Do you have any pain? And if so, where? Again, this brings us back to our favorite acronym in this course, OPQRST. Is that pain constant, intermittent? Is it radiating anywhere? Especially when looking at things like gallbladder pain that could frequently radiate to the right shoulder. Abdominal pain could also be associated with things like stress, fatigue, nausea, vomiting, gas, constipation, or diarrhea. In the case of females, it could also be menstrually related. When assessing nausea and vomiting, we want to assess things like frequency. What does it look like? Does it contain blood? Is there nausea without vomiting? And any foods the patient's eaten in the last 24 hours. Other symptoms like pain, constipation, diarrhea. And again, really just trying to identify, is this an illness? Identify any trigger? Or is there some physiologic cause? In cases of indigestion or heartburn, again, how long? Is it occurring in the stomach, the chest? And is there any changes in position that make it worse? Is it relieved by antacids or acid blockers? And again, is that pain radiating anywhere? For abdominal distension, how long have you had it? Does it come and go? Is it related to eating? And what relieves it? Other symptoms include things like vomiting, loss of appetite, weight loss or weight gain, any change in bowel habits, shortness of breath, or pain. When assessing bowel habits, when did you first notice the change? Is there any change in the diet? Any changes in the stool? Increased gas? Abdominal cramping? When assessing for jaundice, this is going to be a common complication of liver failure. We want to identify, when did it first become more noticeable? Was it associated with any abdominal pain, things like loss of appetite, nausea or vomiting, blood transfusions or tattoos in the past year in the cases of hepatitis, any intravenous drug use, eating raw shellfish such as oysters? To look at urination, again, is there any pain, burning, frequency, or urgency? Any associated symptoms of fever, chills, or back pain that could indicate a UTI? Going right back to week one, again, that order of assessment for the abdomen. We want to get by inspection, auscultation, and then we can move into our more palpation and percussion. We also want to observe the patient's general behavior and position. Look at surface characteristics, which should be smooth with centrally located umbilicus. When we auscultate the abdomen, we want to use the diaphragm of the stethoscope lightly and listen for systematic progression. There's many different orders out there depending on which textbook you like. I like to begin in the right upper quadrant, go to the left upper quadrant, then right lower quadrant and left lower quadrant, as that's the direction of movement of the abdomen. You will see that vary slightly depending on which text you look at, though. Looking at our definitions for this chapter, the first one's going to be a borborygmy. And these are these loud, abnormally loud gurgling sounds caused by hyperactive peristalsis, often heard with things like diarrhea or hunger. In the case of high-pitched clicks, These are more normal sounds, just those normal high pitched gurgling sounds, occurring about 5 to 35 times per minute within a normal bowel. In the case of friction rubs, these are going to be grating sounds heard over the liver or spleen that indicate inflammation of the peritoneal surface. And finally, bruits. These are going to be our abnormal whooshing sounds that we'd hear if there was some sort of obstruction within the aortas. And here we just have a diagram showing where are points where we would oscillate for the aortas and arterial blood system of the abdomen. For palpation, we want to palpate the abdomen lightly for tenderness, looking at muscle tone and other surface characteristics. No tenderness should be present, and the abdominal muscles should be relaxed. Percuss all quadrants of the abdomen using indirect percussion to assess for density of the abdominal contents. Tympany is going to be an expected sound. You can also percuss over the liver to determine its span and descent. When percussing for spleen size, note whether the tympany changes to dullness on inspiration. An enlarged spleen is brought forward on inspiration to produce a dull percussion note. You should also palpate around the umbilicus, looking for any bulges, nodules, or umbilical rings. Palpate the gallbladder, looking for tenderness, as well as palpate the spleen for that border and tenderness. You can palpate the kidneys for presence, contour, as well as elicit abdominal reflexes for presence. Assess the abdomen for fluid, especially in cases of liver failure, anytime ascites is suspected. Assess for abdominal pain again due to inflammation, looking for things like rebound tenderness that could indicate appendicitis. McBurney's point, as well as we talked about on that first slide, which is just that point right there in the bottom lower right quadrant, which is that hallmark classic indicator of appendicitis. Assess the abdomen for a floating mass. Ballottement is going to be a palpation technique used to determine that mass, and can be performed with one or both hands. We actually have a diagram there at the bottom showing how ballottement is assessed. It's also one you may hear again, definitely in your OB module. And here we just have a diagram showing the route we could take for assessing bowel sounds. When looking at infants and young children, the assessment techniques are going to be the same. There are several differences, however, in assessment findings in infants based on just anatomical difference. Children and adolescents may also resist abdominal palpation because they're ticklish. GERD. This is the flow of gastric secretions up into the esophagus. It can be a result of a weakened lower esophageal sphincter or increased intra-abdominal pressure, with clinical findings things like heartburn, regurgitation, and dysphagia. When looking at a hiatal hernia, this is a protrusion of the stomach through the esophageal hiatus of the diaphragm. Muscle weakness is a primary factor, though could also be due to things like pregnancy, obesity, and ascites. Peptic ulcer disease is an ulcer occurring in the lower end of the esophagus, stomach, or duodenum. A duodenal ulcer is most common from a break in the mucosa that forms a scar. Gastric and duodenal ulcers may also be a result of infection from the H. pylori. And here we just have a diagram showing that ulcer forming within the duodenal bulb. In the case of Crohn's disease, this is a chronic inflammatory bowel disease, also called regional enteritis or regional ileitis. Inflammation may occur from the mouth to the anus and commonly affects the terminal ileum and colon. It can also be affected the mucosa ulcerated within fistulas, fissures, and abscesses within the GI tract. Ulcerative colitis. This starts in the rectum and progresses throughout the large intestine. The submucosa becomes engorged and the mucosa becomes ulcerated. It may progress also as a greatly increased risk for colon cancer. Diverticulitis. This is an inflammation of a diverticula, or a herniation or outpouching within that intestinal wall. Presence of food and fecal material can get trapped in there and cause an infection. Patients often complain of cramping pain in the lower left quadrant, nausea, vomiting, and altered bowel habits. They'll also tend to avoid food that's high in seeds, things like corn or strawberries. Here we just have a diagram showing that diverticula, or that outpouching out of the large intestine. In the cases of bowel obstruction, this is going to be a very common one for us in the hospital, especially working med surge. Because again, during anesthesia, we've not only sedated the body, we've also sedated that GI tract, looking at things like abdominal pain, bloating, rigidity. Hepatitis, it has many different forms A, B, C, and they come from an inflammation of the liver from viruses. Common symptoms are going to be anorexia, vague abdominal pain, nausea, vomiting, malaise, and fever. It can also result in enlarged liver and spleen. This liver inflammation may also alter the bilirubin, causing the sclera and skin to be jaundiced or yellow, or the stools to appear clay colored. Cirrhosis. This is a chronic degeneration of the liver tissue. Could be caused by things like viral hepatitis, alcoholism, or biliary obstruction. Cholecystitis, or inflammation of the gallbladder. This could be a result of gallstones, the bile duct becoming obstructed either by edema or inflammation. Pancreatitis is acute or chronic inflammation and deals with the flow of the pancreatic digestive enzymes into the duodenum becoming obstructed. These digestive enzymes then act on the pancreas itself. The hallmark signs of pancreatitis are going to be a steady, dull, or sharp pain radiating into the epigastrium to the back. Patients prefer the fetal position with knees to chest, and one teaching you will see is having them sitting in semi-fowlers with their knees bent. UTI, urinary tract infections. These may involve everything from the bladder, in the case of cystitis, the urethra and urethritis, or the renal pelvis itself. Most UTIs result from a gram-negative organism, such as E. coli, Klebsiella, or Pseudomonas, that originate from the patient's own intestinal tract. Looking at clinical findings of UTIs, the symptoms of urethritis include frequency, urgency, or dysuria. The symptoms of cystitis include the above, plus signs of bacteria and perhaps fever. And for our last slide, nephrolithiasis, or kidney stones. This is the formation of stones within the kidney pelvis. These stones or calculi could be made of everything from calcium salts, uric acid, or struvite. Clinical findings again are going to be fever, hematuria, and extreme flank pain being common. But anyway, that's all I got for this chapter. I'll see you in the next slides.